We're back again. Today we're going to be doing the postpartum period. And again, this is a short, well, not short video, but it's a video just hitting the highlights of 3 chapters. And I want to remind you again that there is in the video series, as we go along with my in-person course, I'm going to be adding in a whole new section where we're going to be basically bringing a patient to lecture and doing some clinical judgment and looking at cues and trying to determine what interventions need to be made so that we can get you ready for next gen NCLEX, which is coming 2023. So if you are taking your NCLEX in 2023, you will have the next gen version. I also have the guided lecture notes that will be in the notes below. Feel free to use those as you wish. I often just write them myself at night. And so if they don't make sense, change it to what you want. You've been given the Word doc version. And my thought process is if you can complete those guided notes from the lecture, then you have a really good overview of the chapters that I'm covering in that module. All right, let's get started. So we are continuing into our birth of our baby has already happened. Now we're in the postpartum period, and this is really the critical time. I know I've talked about a lot of problems that can happen during pregnancy and birth, but the most critical time I feel is this postpartum period, because this is really the transition. This is when that family is starting to figure out who they are, and we're watching for some physiological changes in both mom and baby that are pretty important and can be very acute in those first few hours. So the period after the birth until traditionally it's 6 to 8 weeks, but really we look at the whole first 3 months as that transition period, and we call that puerperium or the postpartum period. And so really it's our 4th trimester, and we have just a little bit of time, usually 24 to 48 hours with them if they gave birth in a hospital before they go home, but then there's a lot of transition that happens after they go home. So in our modern healthcare system, we really need to look at better care for our first few weeks and months of childbirth, because that's when we see the majority of our maternal mortality is actually in that period. So it's a part that's lacking in our healthcare system. So when we're looking at the adaptations that happen in the reproductive system at delivery, the top of the uterus, the fundus, is typically about the level of umbilicus. It might be a little bit higher if it was a very large baby or multiples, but it should be at about the umbilicus. And then every day postpartum, it should move down by 1 finger breadth. And so by the time we get here to about day 7 to 10, 10 being kind of the top of the level, it needs to be returning to a non-abdominal organ. It needs to be back down into a pelvic organ. So let me say that again. By the time we get to day 10, it needs to be below the level of the symphysis pubis, so that and I didn't mark the right area of the picture before, but it needs to be down here by day 10. And if it's not, we need to investigate why. Okay. So when we're looking at our assessment, we're keeping in mind our risk factors. What was her risk factor for bleeding? Because this is when it's going to come into play. And what are our early interventions? We call those cues. What are the cues that something's not going well? And then what are our early interventions going to be? And then our other role is really promoting comfort. And some of those comfort techniques are really just nurse judgment, using an ice pack, creating an ice pack. Some facilities, you make your own ice pack using a baby diaper, and some facilities, they have them pre-packaged. But an ice pack, reducing swelling, reduces pain. The other thing is using medications like ibuprofen. Ibuprofen reduces prostaglandin, and a lot of the afterbirth pain and cramping that's happening in the uterus is a result of the excessive prostaglandins that are happening. So ibuprofen works better in most cases than narcotics do, and narcotics come with other side effects. So we really should be pushing ibuprofen if they don't have a contraindication to it. We also want to get them up and moving, helping them get to that pre-labor state, ambulation as soon as possible, learning all about how to care for themselves, pericare, and I'll talk about that in a minute. And then promoting bonding. How do we promote bonding with this new life that just showed up in this room? And education. I think the postpartum nursing side is really about education, what to expect, what's normal, when should you be calling if something's not normal, and letting them know what community resources are out there. Because like I said, we only have them with us for about 2 days at the very most, and then they're off into the world. So our typical assessments, and again, this will depend on policy, but for those first few hours, it needs to be very frequent, every 15 minutes. And then it will change based on policy. And you also have your new little one that you're going to be doing those assessments on. Looking at our vital signs, sometimes we will see a slight temperature elevation, like into the 99-degree Fahrenheit. I still speak in Fahrenheit, even though we document in Celsius, because that's what I learned. But into the 99 degrees, we don't want to see the development of a fever, which is over 100.4. Initially, the pulse will actually lower because there's a big fluid shift inside the mom. We're going to talk about those changes in a minute. And because the cardiac output is increased and the pressure of the baby on the circulatory system is no longer there, we do sometimes see a decrease in that pressure along with the fluid loss. But then should go back to pre-pregnancy rates. One of the key things we're looking for is if we see a high pulse, if that pulse is rising, that's an early cue of too much blood loss. That is actually one of the earliest cues that you will see. We don't wait for a drop in blood pressure because that's a late cue, but we're looking for a high pulse as a potential, and then we need to investigate that. Respirations are about the same. Blood pressure should be in the normal range. We still can have hypertensive issues if she had hypertensive issues before. So we want to pay attention to what was her normal and then still be watching for those triggers for signs of preeclampsia. And then we really want to manage her pain as best as we can. So there's a lot of controversy about this fundal assessment and fundal massage out in the world. So two concepts here. We do need to assess where the fundus is initially and make sure that it is, within the guidelines. So it should be at about the umbilicus. And the picture you see here is the nurse is putting pressure, holding the bottom of the uterus, and then up at the top, assessing where it is in relationship to the umbilicus. Also assessing, is it firm? That's what we want, because this uterus is clamping down and creating a tourniquet effect to that wound that was created when the placenta came off. So the only way we keep this mom from actively bleeding, excessively actively bleeding, is to keep that uterus clamped down, providing that tourniquet effect. So we are assessing, is it firm? And we're also assessing where it is in relationship to the midline of the body. We know that there are certain things like a full bladder, for instance, that will not allow the uterus to contract fully, and the sign of that is it being maybe one position or another inside the body rather than midline. So that's the assessment. This actually is a very gentle assessment, and it's often confused with the fundal massage that needs to happen if it is not firm or she is actively bleeding. And that's a very vigorous massage to help that uterus contract down. Those two, assessment versus intervention, are very different. But unfortunately, at least in my area, this has become universal of everyone just does the massage very quickly. And with that, they're also doing the assessment. It can be extremely painful for the patient, and it's an unnecessary intervention. So here we're looking at the flow, the blood flow that happens afterwards. It's called lochia. It's not a period. It is all the excess lining and nutrients that were in the uterus that's being expelled, and it's different than the lining that was put there in preparation for a pregnancy that doesn't happen, and that's what the normal monthly period is, the release of that blood and tissue. So we layer it in levels. It starts off as rubra, which is dark red, and you're going to see again each of your reference ranges may be slightly different in this area, but essentially for the first couple of days, it's dark red and maybe even has some small clots in it. And then it's going to change to pinkish brown, which is called serosa, and that's anywhere from 4 to 10 days, 5 to 10 days. And then it changes to alba, which is a whitish yellow, and this is 10 to 28 days. So yes, you can actually have still some discharge and bleeding after several weeks. That is not uncommon. Now, when it becomes uncommon is if you're passing large clots. A clot larger than my fist definitely needs to be looked at. If it is moving through the stages and it suddenly goes back to one of the stages from before, so it's maybe you're in serosa and you move back to rubra and that is sustained, then we are concerned. Now, there is a point 7 to 10 days into this process that there might be 1 or 2 hours that there's a little bit more bleeding, and that's where basically the scab, the eschar of where the placenta was, is released, but it shouldn't be continuous. It should maybe just happen for 1 or 2 pad changes and then go on. We don't want her to be soaking more than a pad an hour, and these aren't your little maxi pads. These are the big pads. These are the heavy flow overnight pads. Some people even use the large pads that are meant for urinary incontinence just for ease of use. But our warning signs again are a clot that's larger than a fist, soaking more than a pad an hour, going back, the regression of the stages, or a foul smell, if suddenly there's a really foul odor. And the best time to teach the mom about this is when we get her up to the bathroom. And we'll talk about that in just a second. So here is, I love the acronyms and mnemonics. So here is just a mnemonic to help you remember what you're looking for when you're doing your postpartum perineal assessment. Looking for redness, edema, ecchymosis, which is bruising, discharge, and approximation of any wound. Are the wound edges staying together, whether it was repaired or not? So if it was a small tear and it wasn't repaired, we want to make sure that they stay together. So interestingly enough, the whole purpose of the swelling in a wound is to bring those edges together so that they can heal. So we do want to reduce swelling, but recognize that if there is a small tear that wasn't stitched, we may need that swelling to hold it together. So the uterus, once I said the process of this uterus breaking down is called involution, and it happens by 2 things: contraction of those muscle fibers, and some women really feel this afterbirth pains, and especially if they've had several children or their uterus was very large and it has to clamp down, so they really feel those contractions. And then the other process is these everything that's in the uterus is actually being catabolized. It's taking care of itself and regenerating that tissue. It's kind of an amazing thing that happens inside that uterus. Cervix, if you were to look at it, now will appear jagged. There's not really any reason to look at the cervix unless we're suspicious that it's bleeding for some reason. And then the vagina eventually will have a return of the thickening, and the rugae, the lining of the vagina, will return to its pre-pregnancy state. The typical textbooks say about 6 to 8 weeks, but it can happen much faster, and it can even take longer than that time period. So we need to let women know that the return of any sexual activity is going to be based on their comfort. There's not an arbitrary 6-week rule, and that is information that has been taught differently. So we typically say by about 6 to 8 weeks, the body has returned to its pre-pregnancy state as best as it's going to. It's never going to be completely the same, but as best as it's going to. And then the perineum, initially in the first week or so, any wound that was there will start to heal, and by about 2-ish weeks, it's going to feel pretty healed. If there are sutures there, that are dissolving, they may not dissolve until the full 6 or 8 weeks. Let's see, what else is on here that I haven't already mentioned? So the bladder will have a lot more volume. There's also a big fluid shift that now happens. So we see postpartum diuresis, and they're going to have a lot of fluid, so large amounts of voiding, not uncommon, but that bladder is going to fill up quicker. And so that will interfere potentially with that uterus clamping down. So we have to be careful about that. Bowel sounds, if she's had a vaginal delivery, you should have active bowel sounds, and it will take a little time after a surgical delivery, a cesarean section, for that to return. Okay. So in that postpartum period, we are doing an emotional assessment, and we're looking at all of these things. We're really paying attention to how well she's bonding with this baby. We want to see good eye contact with the infant. We want to see good posture and comfort with that infant. So for some women, especially with their first baby, if they've never been around babies before, they're very cautious, and they feel like this baby is so fragile that they're going to hurt it. But we want to encourage their interactions. Of course, I know how to hold a baby and wrap a baby and comfort a baby because I've spent my entire adult life around babies, but it needs to be her that learns that. I'm not going home with her. So I want to encourage and praise any of the attempts that the family makes in caring for that baby. Let's see, sometimes if there's been a tear, perineal laceration or periurethral, if it goes up to the urethra, there can be a difficulty in letting loose urine, or they can be very afraid of letting loose urine over that wound. So a couple of things, lots of good fluid to keep the urine very dilute, and explaining why that bladder needs to be emptied on a regular basis. And then the use of the peri bottle, which I'll talk about in a second, but the peri bottle can really help. You can use it at the same time that you are urinating, and that will help decrease that burning sensation. We're always on the lookout for the formation of a hematoma, which is a broken blood vessel in the perineal area. This can become a medical emergency very quickly. So that's an area of swelling and bruising that is getting bigger and has excessive pain. And then another note here, if she had an epidural or potentially even a spinal, she might have reduced sensation to that bladder. That might be the last sensation that comes back. So we, as the healthcare provider, needs to be watching the bladder to make sure that it's not filling up so much that it's going to impede the use of the contractions of the uterus. So here's that diuresis and diaphoresis that are going to happen. And we can see as much as 3,000 mLs per day. So they might be sweating profusely and urinating profusely. And that is a normal expectation. It goes on for a couple of weeks. For some women, the diaphoresis can continue going on until they have their first period. And that is going to depend on whether they are breastfeeding or not. So expected. They will often express hunger right away. There's no reason for them not to eat if they've had a vaginal delivery. Again, with our cesarean section, we want to wait until we hear bowel sounds because there is that decreased peristalsis. Now, the hormone shift that happens can decrease peristalsis for both types of delivery, and constipation is common. And so we need to have that on our radar and really give them some good education about how to avoid constipation. Lots of fluid, good fiber, and even a stool softener, Colace, is recommended because we don't want the fear of straining or constipation to interfere with them emptying their bowels. The joints will eventually return back to pre-pregnancy state. Many women say that they had a shoe size change, and that's because that relaxin worked on all those ligaments and joints. Abdominal muscle tone can be diminished after delivery, and it takes time for that uterus to get back down into a pelvic organ. So she may still have a belly for a while. And some women are very surprised at that. They thought once the baby came out that it all went back to normal immediately. So 9 months on, 9 months off. And if there was a separation of the muscle fibers in the abdomen, the abdominis recti, there are some exercises that can help to knit those back together, abdominal exercises. The skin pigmentation changes will fade over the first few weeks and months, so we can reassure her that that will go back to pre-pregnancy state. Except for the stretch marks, they will often have a little memory there of her foray into motherhood. Respiratory and endocrine systems, these are going to eventually make their way back to pre-pregnancy state. We have a huge shift in hormones in a very short period of time. Estrogen and progesterone quickly drop. Placental hormones obviously decline, and then prolactin levels are going to increase. So there's an inverse relationship to those. If she's not breastfeeding, those prolactin levels will start to decline within a couple of weeks. But with this huge shift and all the other things that have gone on postpartum, she's exhausted. She's just run a marathon. She just delivered a baby. She hurts in places she didn't know she was going to hurt. And she has this fluid shift going on and this hormone shift. It's no wonder that up to 85% of women experience some sort of baby blues in those first few days after delivery. Here are your warning signs. These are things that you want to commit to memory. These are warning signs that look similar to the ones that we saw in pregnancy, because some of them are still related to those things. But we need to give every woman good education. There's some great brochures that have come out from AWHONN, post-birth warning sign brochures. And this information is, if they don't take anything else out of the education you give them in the postpartum time, warning signs for them and warning signs for the baby need to be the most important part. This is the thing they need to remember and have it written down so they can refer to it. So fever of 100.4 or more, foul smelling discharge or an expected change in color, large clots, soaking a pad more than an hour, severe headaches or blurred vision. Remember, we can still develop preeclampsia in the early postpartum period. Visual changes, calf pain, looking for blood clots because they are hypercoagulable after delivery. Swelling, redness, or discharge at the episiotomy, epidural, or abdominal sites. I also like to say also at the IV site. Any burning or dysuria or incomplete emptying of the bladder, shortness of breath, and extreme depression or mood swings. So helping them up to the bathroom the first time, if you're following along with the guided notes, you're going to spend some time here talking about all the things that you need to do before you get them up to the bathroom the first time. Once they have had that baby and we have that big fluid shift, it is not uncommon for them to pass out when they get up for the first time and have orthostatic hypotension. So we want to check their blood pressure first, sit them on the side of the bed for a few minutes. I always want them to have something in their stomach, something with some carbohydrates and some sugar before they get up for the first time. She's going to, if she's had an epidural especially, she's going to stand and do some walking steps there to make sure that her feet and her legs are going to actually hold her up, because sometimes they can feel them before they have strength in them and you don't want them to buckle and fall. And then you are going to ambulate alongside them, or if you have something, an apparatus like this, not all places have it, but this is called a Sarah Steady, and it helps these little flaps lift up here in the back, and it helps you transport them to the bathroom and back to bed. And then staying close by to assist. This is also the best time to give education about how she's going to do her perineal care and the signs and symptoms that she would report. I kind of have a whole little spiel that I do right there at the toilet. So with pericare instructions, we want to make sure you start with clean hands and that you have a peri bottle that is just water. We don't have to put anything special in it. I have a picture of it in the next slide. We're always going to use it to squirt front to back. Signs and symptoms to report. Nothing in the vagina until you feel ready. And that may be before 6 weeks. It may be after 6 weeks. They do recommend that lochia flow has stopped before you resume sexual activity. But in the old days, and even I have done this, I used to be very strict. Nothing in the vagina, nothing for 6 weeks until you see your doctor and they approve. Well, that's not really the education that we're giving women anymore. Remember, they are the owners of their healthcare journey and they are able to make these decisions for themselves. Here's that peri bottle that I talked about. These one size fits all underwear are often available in the hospitals, and they're just a stretch mesh panty. And you can cut along the edges here if you need to make them a little bit larger if they don't fit. The large pad that I talked about, Tux pads, these have witch hazel in them, and witch hazel is a great substance that will help with swelling. And so these will help both on the perineum and in the hemorrhoidal area. That's what they're marketed as, but they work on both places. And then this is a great recipe. Ideally, women will have made these before they go home, but they can make padsicles at home and have them ready and just keep them in the refrigerator. And here's the recipe. If you're going to a baby shower or have a new mom that you want to bring a gift to, give her all the supplies, or better yet, even make the padsicles yourself, and then she can just pop them in her freezer, and I guarantee that'll be the best gift that she receives. Talking about Kegel exercises. So Kegel exercises are essential after delivery. And interestingly enough, this is an aha moment for me recently, is that urinary incontinence in women is an American thing. It's not accepted as normal in other countries. In fact, in France, when you leave the birth center or the facility where you've given birth, you stop by at the pelvic floor therapist before you leave, so that you can have all the tools and techniques that you need. So Kegel exercises are very important. The most important part is teaching people where those muscles are. So if you can sit up straight and tall, you want to squeeze the muscles below it in the area where you would stop the flow of urine. And just as a side note, men do have perineal muscles as well, and they can have pelvic floor muscle issues. So this is for both sexes, but you want to squeeze those muscles as much as you can, like going up an elevator, and then slowly let them down. And doing that several times an hour and over several weeks, also throughout your life, will help to strengthen that muscle group, because as you know, if you don't use a muscle group, it becomes lax. So important information about how to use or do a Kegel. So obviously this is a Instagram setup photo. It's not real. But these are some of the teaching topics in the postpartum period that we are thinking about. All of these things are education topics. Obviously, you're not going to just have a class for this very tired postpartum woman, although we used to round them all up and take them to class. We do want them to have some sort of education. Ideally, it's going to be a combination of spoken, so you're going to point out the important things, written so they can take it home with them, and maybe visual so they can see things on a video. Here are more teaching topics, and you're going to want to take a look at all of these. And then when can we expect ovulation and the return of menstruation? Well, it depends. It depends on lots of things, and so we don't know exactly. Here's the kicker. You don't have a period until after you've ovulated. So if you're going about your merry life and you're assuming that you haven't ovulated, you can ovulate, and it can sneak in there and you can get pregnant before you even have a period. So I'll say this, lactating women, it does decrease the chance of ovulation, but we can't depend on it unless you're not too worried about being pregnant again. So there's lots of hormones that go into this process. Non-lactating women, we can expect the return about 4 to 6 weeks after birth, and lactating women, it's going to depend. It's anywhere from 2 to 18 months, but we need to really plan on 6 months when that baby starts eating solid food. we can plan that breastfeeding will reduce, and most likely you will be ovulating again. So this is where the birth control discussion needs to happen. Now, there are some cultures that believe as long as you're breastfeeding even a little bit, you will not get pregnant. And it's just not true. So other challenges that we really see families face after discharge, and this is really a nod to our current society, is we have lack of role models for breastfeeding and infant care. I've talked about that in my very first lecture. It's just not common for us to see women breastfeeding. We shy away from that. So we don't know what it looks like. We don't know what to expect from it. Lack of support from the new mother's own mother, because often they didn't breastfeed, or maybe they live far away. Maybe a non-supportive, overwhelmed, or fatigued partner. Feelings of isolation, especially in times of, say, a pandemic. Feelings of not having a connection with other people. We have shortened hospital stays. Prenatal classes usually focus on before birth and often don't really cover a lot of post-birth. And limited access to education. So where are people going to go? Well, hopefully they're going to come to YouTube and spend some time on some good, solid videos that have reliable resources talking about what to expect after delivery. And they have you as the nurse to ask questions and depend on. You can even post things on social media. We have a lot of medical social media influencers that are out there now that are trying to get this information out to the average person. Multicultural, there are lots of beliefs, practices, and customs, and the best way to know that you are remaining culturally competent is just ask them. What is it that you, what are your customs? What are the things that you believe and would like to practice after delivery? And it might be that it has to do with food. It might have to do with some other customs, but as long as most of the time these don't interfere with our medical care, and we need to just accept what it is that they would like to do. Bonding. When we're talking about bonding and attachment, bonding is what happens first before attachment happens, and bonding really needs to be close physical contact. Up close, spending time with the parent, spending time face to face, what she's doing right now. They call that the on face, ENFACE, face position. This is eye to eye contact. It's really unidirectional from parent to infant. This is that part of us that bonds with this newborn and encourages us to want to protect it, even at 3 a.m. when we're exhausted. And then attachment is both directions. And this is when you're going to see a strong affection between infant and the significant other, whoever that may be. So bonding needs to happen before attachment can happen. And let's talk about some of the ways that a nurse can encourage bonding. Well, we can encourage unwrapping that baby, spending time skin to skin, touching, talking, looking at the baby. This is one of the reasons that our normal newborn nurseries went away. Yes, sleep and rest and recovery is important, but that bonding is even more important. So encouraging the interplay between the caregivers and the newborn are essential. For the partner, often they don't have a full accepting of the pregnancy and process until they see the baby. It is not uncommon because they don't have the ability of feeling the baby move inside them and that sort of thing. So seeing that baby is often the time when that it really hits home that there's this new little one. And so the partner will have that process of bonding and attachment as well. And you can see the steps here. This is what is talked about in your textbook, is how that process starts to take hold. Some factors that will affect bonding and attachment are the parents' backgrounds and the infant's temperament, and if they were separated right after birth, if there are policies discouraging them from exploring their newborn, if the staff are indifferent or don't support the parents. These will all affect attachment. Really recognizing that what your upbringing is going to affect how you parent your own children is some self-awareness that needs to happen. Oftentimes, I've seen enough deliveries now that I don't always get super emotional with every delivery, but if I turn and look at the partner and see a reaction that looks like this, that's what's going to get me. Just that overwhelming emotion, expression of emotion, that's when I'll start to cry. So there are 4 stages of becoming a mother. This is one of those NCLEX questions that they really love to ask. So spend some time here looking at this concept, this theory. And variables that are going to affect how this mom and baby form a bond and attachment are, again, socioeconomic status, the relationship with the father, what the birth experience was like, what kind of support they have, what the relationship is with their own mother, if they have a history of depression and anxiety, and the infant's temperament. And we all know that they come out differently. Okay, we're going to jump into talking about lactation, and this is just a reminder that this is a feedback loop, that breast milk is made based on stimulation and how much milk is taken out of the breast, and so that encourages more milk to be made, and so it's a process. And I want you to think about what is something that we use pretty commonly in modern day society that can interrupt this process. And if you said a pacifier, you're correct. And now I am not saying that you can never use a pacifier, but we know the early days when this foundation is being set, if you use a pacifier and interrupt the cycle, we can actually decrease milk production. This is the normal feeding position. This is what we call the ventral or lying down position. And actually, if you're having issues as a nurse helping this baby get latched, put mom in this position, and these babies are amazing. They can many times figure it out for themselves without us being all involved. There are lots of benefits to breastfeeding, and I'm going to let you take a look at this. We don't talk enough about the benefits to breastfeeding. Now, your baby will thrive on formula. We live in a society that has access to clean water and the ability to obtain formula. Your baby will thrive on it, but it is different. And there are certain things, especially the immune system, that are being laid down that breastfeeding will support that formula simply just doesn't, because it doesn't have the immune properties. There are benefits to the mom who breastfeeds. And when I say breastfeed, I mean chest feed as well. It can be these benefits have been shown even for short periods of time. I like to say that a month, a week, a day of breastfeeding is going to give some benefit. So even if it's not feasible for that mom to continue for the recommended period of time, which the American Academy of Pediatrics says exclusive breastfeeding for the first 6 months is recommended, and up to a year with the introduction of food, or as long as the mom and baby still find it mutually agreeable to do so. And we're looking at research coming out that says breastfeeding protects against childhood obesity, which is fascinating. And there is that microbiome, that whole colony of bacteria in your gut that is being developed and fed based on what we are putting into our bodies. So a breastfed baby has different bacteria that are being introduced and different carbohydrates that are being introduced that feed those bacteria. And this is why we see immune system development greater in those that are breastfed, that last throughout a lifetime. Okay, now we're going to move into some of the postpartum disorders. So the things that we are most concerned about: hemorrhage infection, thromboembolic disease, and postpartum affective disorder, or mood, used to be called mood disorder. So here are some of the things that happen in delivery that can put someone at risk for postpartum complications. And you'll see it's a lot of the things we talked about in our last lecture. Operative procedures, so forceps, cesarean birth, or vacuum extraction puts them at higher risk. History of diabetes, prolonged labor more than 24 hours, having a urinary catheter, being anemic, multiple exams during labor, vaginal exams during labor, a prolonged rupture of membranes more than 24 hours, having to manually extract the placenta. Other things that put them at risk is having a short labor. And this is specifically for hemorrhage, and the ones I listed before were for infection. Uterine atony, that uterus not able to clamp down, having a placenta previa or abruption, labor induction, operative procedures again, retained placental fragment, prolonged third stage where the placenta takes longer than 30 minutes, more than 3 births closely spaced, multiparity, or overextension. So all of these are things that put them at higher risk for complications, including infection and hemorrhage, which are the two things that we're most concerned about. So when we're looking at blood loss, we've moved away from just eyeballing it to actually quantifying it by measuring. And the current research is saying anything over 1,000 milliliters of blood loss is going to be considered a hemorrhage. And we do talk about hemorrhages in stages, but any amount of bleeding that places the mother in hemodynamic jeopardy can be classified as a hemorrhage. So looking here at when you're going to see shock due to blood loss. Now, this is where it's a little bit different than maybe what you've learned in some of your other courses. So maybe in your other courses, you've been taught that low blood pressure might be an early sign. But in women, remember, they have all this extra blood flow and all this extra blood volume from pregnancy. So it's going to be a long time before you see a drop in blood pressure. So here are the degrees of shock and the signs and symptoms that go along with it. So you see we have to be moderate, like a 20 to 40% blood loss before we even see hypotension. Okay. And this is just another look, looking at your blood pressure. It's not going to be decreased until we have 1,500 to 2,000 mLs of blood loss, typically in most women. So some of the causes, the most common cause is uterine atony, and that just means the uterus is not contracting down and providing that tourniquet effect. Other reasons might be a laceration of the genital tract, either up in the vagina, maybe in the cervix. Episiotomies can bleed pretty extensively, especially if a large blood vessel was cut. There might be retained placental fragments that's keeping the placenta from being able to clamp down. Uterine inversion, most common reason this happens is someone got over anxious to get the placenta out, a provider, and pulled on the cord, and they can turn that uterus right inside out. I've actually seen that happen one time. Coag disorders, if she already has an issue with clotting, then we're going to see potentially that have a problem now. And then hematoma, which is that bleeding into the tissue. And those often have to go to the operating room to be evacuated and find that bleeder and have it stopped. So when we're thinking about hemorrhage, we want to be thinking to ourselves the 4 T's. Which of these things is causing the bleeding to happen so that we can stop that cause? Because we have to get to the cause in order to fix this problem, and we don't have a lot of time. When I say postpartum hemorrhage, I mean they can lose a large portion of blood in a very short period of time. So our role as the nurse is early recognition. And how are we going to early recognize? By doing those postpartum assessments, actually going in and doing them. We want to focus on that underlying cause, try to figure out what it is. Our initial reaction is uterine massage to try to get that uterus to clamp down so that we can stop that flow of bleeding. We're going to be doing other things at the same time, but the initial nursing intervention, uterine massage or fundal massage. And that's different than that assessment I talked about earlier. And then it's going to move to the provider to assess if there are placental fragments that need to be removed. Then we need to be thinking about antibiotics, especially if we've had an internal exam, because that's going to increase chance for infection, and then repairing any of those lacerations that might be causing the problem. So nursing management, we are looking at how much bleeding is coming out. We're going to be saving everything over to the side so we can actually quantify it, called a QBL, quantified blood loss, or quantitative. And then fundal massage, we might be administering uterotonics. We need to know what those are, who they can go to, who it's contraindicated in. Fluid administration, have the access to give large amounts of fluid very quickly, monitoring for those signs and symptoms of shock. And then if we move into other disease processes like DIC, which we're not going to cover in this course, we need to be ready to move to a higher level of care, like an ICU situation. So those of you that are going into ICU because you never want to see a pregnant woman, or that's not the population you want to handle, unfortunately, you do still see them for certain reasons. So spend some time in your book, look at your risk factors table 22.2 and your uterine tone 22.1, and understand risk assessment, knowing that we did this way back in pregnancy or in labor, and we assessed whether she was low risk, medium risk, or high risk, and she can move through these stages during pregnancy. We want to make sure that we have our interventions ready. So in the community I work at, in the hospital I was at, we needed to have blood on hold because they might have to drive it over from another facility. And so if I'm suspicious that she might be at higher risk for bleeding, I want to have that available to me and not have to wait the 2 or 4 hours it might take to get blood to me when I need it. So thinking ahead, being prepared is really important. This is the Postpartum Hemorrhage Project. This is one of the things that AWHONN, which is our professional organization, has put together. And this is where QBL, quantification of blood loss, really started becoming popular. And we've actually seen a decrease in postpartum hemorrhage and maternal mortality due to this process. This is where everybody gets on the same page. Everyone learns how to respond to this the same way. We do drills, we learn about it, we do continuing education about it, recognizing that we need to catch it early, and then having a standardized way of responding to hemorrhage, and it's saving lives. Here's one of the training type things we would use is just learning to, with our eyes, to think about how much blood loss we've had, knowing that 1,000 mLs we're moving into the hemorrhage stage, and recognizing what that looks like. Now, of course, we will weigh it, but this is not real. This is just for training purposes. And looking at when you're soaking the bed, you're at 1,000. If you're spilling off onto the floor, you're now probably at 2,000. Just that early recognition. And here are your uterotonic medications. You want to make sure you know all of these. Now, some of these, Pitocin and Cytotec, are also used in the induction of labor in much smaller doses. But the others that are listed here, Methogen, Hemabate, and TA, are never used with a baby on board. So you need to know the difference. A couple of sneak peek tips here. Hemabate needs to be used very cautiously in someone that has a history of asthma, also causes as a side effect some of the worst diarrhea ever. Methogen, a vasoconstrictor, should never be used in someone with hypertension. So these are important for us to remember because these are the only meds we have to deal with postpartum hemorrhage, and we can actually use all of them in one person. And knowing that she should not receive certain medications may be up to the nurse to say, oh, remember she came in for high blood pressure. So where a good handoff report comes into play, so we wouldn't want to give Methogen. So spend some time there. And here are the dosages. So when a woman is having a hemorrhage, instead of just giving her packed red blood cells, we look at giving her some of everything back. So a MAP pack, a massive hemorrhage protocol pack, includes these things. And this is part of that AWHONN hemorrhage project, is responding in the same way to hemorrhages rather than providers just kind of making up their own protocol. We know we have the best outcomes by giving these things back. So 3 units of packed red blood cells, 2 units of fresh frozen plasma, and a single donor platelet in that ratio. That would be considered 1 MAP pack. And I've actually seen hemorrhages where we do 2 or 3 or 4 MAP packs. We need to have an ability to give things rapidly, because if she's losing fluid rapidly, we have to be able to give it back. This is something that goes over the IV bag. You take it off the pump, and now it's free flowing, and we call this a pressure bag. It pumps up with this little bulb here and basically squeezes it. It's the equivalent of the nurse squeezing the bag to make it go in faster. And this is called a rapid infuser, and you have the ability of 2 of these. This machine takes 2 people to run because these go in about 5 minutes. And if we are having a massive hemorrhage, we might need to massively transfuse. You also see these in ORs and in trauma rooms. Other tools that we have at our disposal for a hemorrhage, this is called, well, the brand name is a Bacri balloon, but this is a balloon that is placed by a provider that actually increases or provides tamponade from the inside. And this allows there to be pressure to stop that bleeding. This is called a bimanual compression. And yes, that is a fist holding up against the uterus. And on the outside, this is done by a provider. And then last but not least is a surgical procedure. It's one of the newer things that they'll do. If she's still massively hemorrhaging, they may take her to the operating room and do a B-Lynch procedure where they clamp down the vessels that are coming to the uterus in a last-ditch effort to try to save the uterus and save the patient. So sub-involution is when over the weeks of time, the uterus does not go back down to its normal location of being a pelvic organ. And so there is usually a cause for that. This is one of those signs and symptoms that we need to have the mom report, because if we have sub-involution, it's not actively hemorrhaging, but the uterus is just not going back to its regular size. There might be retained placental fragments, that distended bladder again, maybe there's something going on there. If there's some sort of fibroid or infection in the uterus. And so we need to investigate that. So we're looking at 10 days. We should not feel that uterus. It should be all the way back down. So by the time she comes back for, if we're doing the recommended 2 to 3 week visit, postpartum visit, and again at 6 to 8 weeks, we should not be feeling that uterus at that time. And that actually is a change. We used to say everyone can just wait until 6 weeks to come back. But now they're recommending, because we have so many issues in the postpartum period, that they come back at 2 to 3 weeks and then again 6 to 8. As I've mentioned multiple times, she is hypercoagulable state in the postpartum period and pregnancy altogether, but in postpartum period especially. And so we want to give her good signs and symptoms to look for. She is at higher risk for a clot. And so all the same things you've learned about DVTs and venous stasis. We don't want her in a propped position for very long. That would cause venous stasis. And we're going to use some nursing interventions while she's in the hospital to prevent those DVTs. The old-fashioned TED hose, and then these are called ICDs or SCDs, depending on where you live. Nursing intervention for the prevention of DVTs. And then explaining to women the importance of these while they're in bed, especially after a surgery, helps them to be more accepting of the procedure. It's not a procedure, of the intervention. And then once again, here I'm bringing up AFI again. Sorry, AFE, that is wrong. Amniotic fluid embolus. And in the immediate postpartum period, we are still at risk for this very unfortunate condition. Postpartum infections, anything with a fever of 100.4 or more, we are definitely going to be investigating. And it's really kind of assumed if you've had a baby in the last 30 days that it's probably infection in that uterus, unless we see it somewhere else on the outside. So that needs to be treated. It can become septic very quickly. We're also looking out for wound infections, like in the cesarean wound or the episiotomy, if she had an episiotomy, and a urinary tract infection. And then mastitis, which is infection in the breast tissue, not the breast milk, but in the breast tissue. That needs to be managed as well. Usually we're looking at broad spectrum antibiotics, fluids, definitely to increase the urination for a urinary tract infection, and then breast emptying and antibiotics for mastitis. So remember I said it's not an infection of the milk, but we still need to get the milk out of that breast, or we're going to actually make the condition worse. Now, there are some providers that are really against that milk being used for the baby. If it's too painful to actually put the baby to the breast with mastitis, you still have to pump or get the milk out and decide what to do with the milk at that point. There's no problem in actually giving the milk to the baby because the milk's not infected. The number one way to prevent infection is still wash your hands. Wash your hands. Number one way to prevent infection for yourself and spreading it to others. Let's see, teaching visitors, back when we had visitors in the hospital, no, I'm kidding. Teaching visitors about hygiene and washing their hands before they come to see patients, super important. Letting them know that it's not okay to come visit a new baby at home with sniffles or other signs of infection. And then teaching people to wash their hands before they care for themselves. Very important education. So engorgement, we have discussed this before, we'll talk about it again. Engorgement is that excess fluid that is third spaced into the breast, typically in the first couple of days after delivery, as that big fluid shift is happening. It usually is at its worst 3 to 4 days after delivery, which coincides with the mature milk supply coming in, with that big shift of hormones. Usually the mom is at home at this time, and it makes it very difficult for the baby to actually latch onto the breast. So some things we can do: cold packs, ice packs on top of the bra, warm packs, alternating with warm packs, and warm showers to help empty that breast, and really just massaging that excess swelling and fluid out of the way will help the baby to be able to latch on. As a lactation consultant, this is one of the most common phone calls we get. 3 to 4 days, my baby won't latch. Everything was going great. Now my breast is hard as a rock and I can't get the baby to latch, or there's now a wound on the nipple because the baby didn't latch well. And so we talk a lot of people through this in our phone consultations. Cabbage actually is a great tool that can be used on the breast, and just green cabbage. You can put it in the refrigerator to make it nice and cool, tuck it in the bra, and there are chemicals in there that will help reduce the swelling. Works on other parts of the body, like if you have a swollen knee or something, you can use cabbage. And then this is just showing that a bag of frozen vegetables is a great ice pack that can be reused. Put it back in the freezer in between use. Mastitis, again, infection in the breast, and it needs to be treated because it can turn into a bigger issue. And so you see here the list of things that need to happen for the treatment of mastitis. Again, empty the breast. All right, we're going to move into postpartum mood disorders. So like I said, 25 to 85% of women experience some sort of baby blues in the days after delivery. Mild depressive symptoms, sometimes mood swings. Women will be crying and they don't know why they're crying, and they're saying, I don't even know why I'm tearful right now, but it's because of all the changes and emotions that have gone on with this baby. Usually peaks at the end of the first week, should absolutely be resolved by the end of the second week. If it continues, if it starts to get worse, if we start to see other signs, then we're concerned. And these are the points that we need to educate to the partner as well as the patient, because they might recognize it before the patient does. These feelings, if they continue, will lead to poor bonding, alienation, daily dysfunction, and maybe even progress into psychosis. So when we teach about baby blues, these are the symptoms that we're talking about. I know these ranges are a little bit different. We'll just make it simple. Usually the worst is in the first 5 days, and it really should be resolved within the first 2 weeks. These are signs of normal baby blues: self-limiting, there's insomnia can be involved, irritability, emotional lability. And then signs of postpartum depression is when it definitely is lasting into the second month. And all OBGYNs and midwives have been trained in postpartum depression and treatment for postpartum depression. And so we need to send them back to that provider. They can help them, and they recognize those signs. And of course, if we have signs of postpartum psychosis, then we need to not leave them alone with the baby and seek immediate attention, even going to an ER if need be. One of the validated scales that we use to determine the postnatal depression is used right before they go home. So this will kind of give us an idea of where we're headed. First of all, if they've had postpartum depression before, they are at risk again. And so this is the Edinboro Postnatal Depression Scale, or EPDS, and it is self-scored. And looking at these 10 questions, we want a score of less than 10. And if the answer to number 10 is anything other than never, because that's the self-harm question, then we need to get social services involved and have them reach out with some resources right away, because this woman is at higher risk of developing postpartum depression. And then this is the Postpartum International Support Group. It's online. I've given you the website here. They have Zoom postpartum support group classes. They have classes for all sorts of families. They have classes for adoptive, or support groups for adoptive moms and single moms and teen moms. And it's just an amazing organization. And it's a way of getting that connection for the women that need our support and our help. And then I'd like to remind everyone, especially as I'm here in my midlife, that these days and sometimes nights feel very long, but these years are very short. So don't wish away these postpartum days. Don't wish away those early days of childhood, because before you know it, they'll be gone. Thanks for listening.